And Jack, I really enjoy that. Don't get me wrong. I tease you all the time, but the way you put it in a very clear sense, and I'll explain the math later to Dr. Buckman, but it's really, really interesting. I compliment. That was a fantastic lecture. Getting back to it, both of you, based on what I heard, and Steve, looking at your results, it seemed to me, and again, this is anecdotally looking at it, your results were much better with distraction than they were with monoblock. So is monoblock archaic? Is it gone? The fact we have distraction, would anybody, what are your indications of doing monoblock versus distraction?
Yeah, I would disagree that they're necessarily better. I do it, they're a little bit better. It depends on what you're sort of looking at. But some of those kids, those two girls that I showed you at the end, I mean, those are home runs. I don't know anybody else, not just me. I would say Dr. K, getting those results, I will not see those results in the other ones that are there. I like distraction for lots of different reasons, like the orthodontics involved. I think we can actually really believe in the functional matrix. I really believe in the recoil of the soft tissues having a problem. I like the idea of overcorrecting. I don't disagree at all with Jack about the lack of growth, except for the fact that he thinks it's causal. I don't think so. I actually think it's there in the genes. So you'd have to actually have a bunch of other kids that you'd be comparing those to see what they would be growing like. They don't grow either. And when they don't grow, they end up having problems and needing trachs and they have exorbitism. So if it's sort of like a kid that's got hemifacial microsomia and you have a little small mandible, you distract them and they're not growing much. I don't think it's because you're cracking the mandible away from the growth center. They weren't going to grow much to begin with. I never apologize for actually trying to make a kid look normal. I mean, I'm not on the defensive here. He can show as much as he wants about whether or not we figured out, are they sort of, their mental capacity up or down or something. I don't think we're changing what their brain is doing. I know ICP, high ICPs are bad for you. Now you can do an expansion. Remember I showed you a kid there, had a shunt, which by the way, shunts, not a great life. They're not doing great either if you want to compare it, right? High ICPs, everybody agrees. So what's your alternative, right? Doing an expansion. Now if they already have a shunt, you have to do an expansion. You want to do that at the same time as the frontal facial area. I don't like doing young kids. But if you have a kid that's got exorbitism and it looks like they have a trach, by the way, look at trachs. Look at all the things. You know what it's like to have a kid that has a trach? Go and deal with those parents for a long time. And deal with the fact that they have to worry about bad showers, their voices, what's going to happen, how long those things are in there. This is not sort of gives where those things are. I think distraction is reasonable because the other there. But the answer to your question specifically is it depends on the case. I see parents that are not going to be able to distract. They're just either too far away, they're not smart enough, they're not going to bring the kids back, they're not compliant. There's something about getting an operation done, and this happens a lot with lots of distractions. Even, for instance, if you're going to do a mid-facial advancement, even when they're older because they weren't done. If they are not going to want to be compliant and come back, there's something, especially in older kids, they'll say, do 2 operations, do 2 reports, wait a year, and if it relapses 3 or 4 millimeters, do a final osteotomy, because they don't want to wear that thing for 3 or 4 months. Now, most of them don't, and you can get them there, and they're fine. But if they're not candidates, in other words, you have to look at that. If they're not candidates for distraction, then of course, that's when I'll go back to the other one. If you ask me what I'm mostly doing now, I'm mostly doing distraction that's there, but there are people there. I don't necessarily think, see, it depends on the results. I do think you're going to get a little bit more long-lasting results because of the other there, but I will put up some of those results against antibodies, as they've gone on there and so on, some of those difficult cases, so that whether they have distraction or they don't. The big thing about distraction, and what I find sometimes is to disagree. When I find other people have done distraction, it is the Joe Cross situation, where they just distract them, and then what they do is they take a flat dish face and they've distracted it out and they got a flat dish face. So unless they do the appropriate stuff, it's the other reason why I like external distraction with mid-face being brought out. If you think about it, they have flat faces and dish faces, so the idea of actually having a central pole, I think is much more attractive because it takes their face out, makes a facial, what Dr. Kawamoto used to call a facial bend, and that used to be important.
I'd like to make the point that what I'm finding, and I guess our numbers were, I'm surprised a little bit of it because I haven't seen the filling numbers in a long time. I didn't recall that, but I used to average about 7 to 9 monoblocks a year. We're probably down between 4 and 5. So I think our comparison would probably be quite a bit. But I'm finding that those numbers have gone down in part because of the paradigm shift, meaning which I think I'm getting better retention of the frontal orbital advancement that I'm doing initially. And so that gives me a disparity and disconcordance with my frontal hypoplasia, which is now less than my midface hypoplasia. So I can't in concert advance the whole monoblock anymore. As a result of being a little bit more successful on the frontal orbital. So I think as I'm starting to learn a lot more about this and looking at each surgeon, it depends on what our surgical paradigm treatment in the entire landscape for each of these kids. I find, Steve, that I can't move these patients forward more than about 6 or 7 millimeters because of the soft tissue drape. You're getting a lot more of an advancement. I find that the soft tissue drape is going to want to pull that back. I know you're putting bone grafts in, and I've done that, but that's the reason I do distractions. I feel like I can get that. I don't know if the rest of you have found that to be the case.
I will say that I completely agree with what Mark's saying about the frontal orbital advancement. I've gotten, Mr. Overcorrection, I've gotten to the point with these kids, when you're doing their original frontal orbital advancement, not only am I going about 3 centimeters, I'm talking about, especially if I go with posterior distractions and you don't have the bit where it's hard to close the skin if they've done posterior distraction. If you haven't done posterior distraction, close the skin. But I am going forward and down because I get gutsier and gutsier from the standpoint, not about safety because it's easy, but dealing with the parents because I will bring that supraorbital bar forward and down so the nasion is almost at a ridiculously acute angle. I've never seen a kid not relapse a little bit and come up. So our paradigm is going a lot more to subcranial to 4.3s, not even going back intracranial because I will have neurosurgeons use stealth for us to make the osteotomy as long as they don't have a low cranial base, and then we're doing a 4.3. But you should be able to just look at that kid. If you have a great forehead that's out there, it's almost like you can point and say, that's a little 4.3. It looks like a little 4.3. So as more of those kids, as we get more and more gutsy and more aggressive in the frontal orbital advancements when they're young, I think they're doing it. Plus, posterior distraction means, and there's another thing I like is we're waiting longer so like we do that frontal orbital advancement too. And I've always believed in that. That's why I do even regular synostosis at 9 or 12 months of age. I've always felt that the substrate is better. So now, if you do early posterior distraction, you're doing that frontal orbital advancement sometimes a year and a half. They don't have that thing, they don't have pressure, and I think the substrate holds a lot better and is much more long-lasting. So you are getting more of 4.3s, and I completely agree with you why that's there. But when you do it, then this is what you agree.
So I think we'll maybe take a couple of questions, and I see there's a button that you're supposed to push. And you have a microphone. Yes, Don?
So, first of all, those are 2 absolutely spectacular talks. Jack, you're astounding us. That was awesome. Steve, one of the things that Vincent Whitaker used to talk about was the biological boundary. And I remember thinking at the time, well, that's a lot of crap. But, I now believe that he probably had something there, and that particularly in these syndromic kids, that there is a predetermined pattern of growth that you may temporarily affect with all our machinations. But that ultimately, unless you do something that goes and holds it beyond while they're going through the growth, you're going to end up with a predetermined growth pattern for whatever disease it is. Just like to hear your comments. And by the way, your focus on the eyes and the zygoma in those kids, those were spectacular results. We've seen so many patients. I remember seeing one of Joe McCarthy's presentations where the only good-looking thing was the X-ray. These patients they had been over-operated on, and the eyes looked awful. And it was the most telling stigma of their procedures.
So I want to address the second thing first, because it really is both. By the way, I love that question because it gets back to everything I've done about research and so on, but I want to hit the second thing first. Yes, what you just said is so true. The best thing that some of these people look at is their X-ray. There was a group of people that came in from the AO giving this thing, looking at orbital floor fractures. And this German group that was doing all of this, spending billions of dollars on these. They would figure out what the non-orbital side was. They flipped over to the other side. They'd make these pre-implants, VSP. They get all this stuff done. It was perfect. They would show the X-rays. They were gorgeous. You couldn't show the difference. The computer made everything like it was. And it wasn't until the very end of the talk. There was a bunch of oral surgeons who were showing this at Michigan. They showed a couple of cases. They looked terrible. So the X-ray looked great. I guess they have to hold the X-ray and get back in. But what you said about the soft tissues is so important, and I know that I'm overstating it. And I love when when Bob was, saying, I guess you don't have any complications, I do push the envelope from a hyperbole standpoint, but to make you think about it. That's what I'm doing. I'm going to have this. That soft tissue thing that you're talking about is so important because it's why VSP, in so many ways, is a joke if you just look at that. The soft tissues are unbelievably important, and how you look is there. So I don't care if you want to use a little VSP, but if you don't have the eye that we're talking about, and a lot of this does come down to aesthetics and what they look at. If you don't have that eye and you're not looking at that, it's literally a computer painting something and you doing it. There is a little bit of art to it. There's a little bit about splines and curves. The idea that you're going to get that with VSP, I can't tell you the number of things. I've had an oral surgeon that works in my thing. He had a person that had Mobius syndrome, right? Did whatever the computer did. Well, the girl can't close her lips. She's right, right where she should be according to the x-rays and the cephs. But she doesn't have movement. He had to impact her a lot more. That's not on the VSP. That's in your brain. Now the answer to this, so don't leave your brain and have some guy in Denver show you, beautiful things with computers. I think it's fine to have a learning tool if you want it, but it's not fancy. The part about the biological boundaries is really sort of near and dear to my heart because Linton was, and I trained there, Linton was an idea man, but he wasn't a research guy. So he was a very great empiricist, and I think Lamarck takes a huge hit. I'm a Lamarckian in a lot of ways because, essentially, Mendelian genetics and people like Jack and Brake, they can get computer stuff that will work, but sometimes you have to believe your eyes. And at the end of the day, they did a randomized placebo trial looking at cholesterol-lowering drugs. They spent a huge amount of money, and they did it up in Boston. Then they did another one in the Southwest. And after spending millions and millions of dollars, they came up with the exact opposite conclusions. So it's not saying you shouldn't try your best, but believe your eyes. The functional matrix comes out of Wolff, and the biological boundaries comes out of the functional matrix. So what Linton was seeing is the same thing as Enloe was seeing when he talked about what they call resorptive surfaces and negative surfaces on the face. But he didn't give any biology as to what that is. It's from the recoil. It's from the forces that are there. Jeff Fearon and I talk about this a little bit. When you take the cranial vault and you do what you do, and then you put the galea back, immediately you have recoil forces that are coming back. So those functional matrices that he was talking about were the soft tissue forces that try to relapse what you're doing and the lack of genetic growth that are not going to save it because you're not changing it. That's why overcorrection is so important in changing it. The reason why distraction changes the biological boundaries is because it stretches out that functional matrix. A paper was done, I think it was by Jeff Goldstein a while ago, where he took a bone graft in an animal and put it in the midface, and it resorbed. He did tissue expansion on the opposite side of the same bone graft, and the resorption was 60% less. So not thinking about the soft tissue envelope is like not thinking about an elastic and what an elastic on an orthodontist on a tooth can do. Right? You look at an x-ray, it can move it. It can move those bones. So can we, and that's what distraction does. So my thoughts are, you have to change those boundaries by stretching them out in some way, and that's the upside of doing distraction. But if the person's not a distraction candidate, by the way, doing 2 operations is a poor man's distraction. So if you did an operation like Le Fort 1 that you did, but it was 12 or 14 millimeters, as long as I explained to me to distract or we do it, and then I'll come back a year later, but it's not going to go back 14 millimeters. It's going to go back to about 2 or 3, and I'll do a finishing osteotomy. It's not what I initially want to do, but sometimes you have to take those things out to do a finishing osteotomy anyways. But what do those operations do? They stretch out the functional matrix, that biological boundary. So I think the point is all there, and what we're seeing is important, and don't think Lamarck is a bad guy. Being a clinical fox is really important. Don't drop your clinical skills in your eye and be fascinated by these computers. It depends on what the patient looks like. And believe me, they care what they look like. And that's what Jack's stuff doesn't talk about. Every kid wants to look normal. I don't know the kids that don't want to look normal. Maybe they do in Georgia, but they don't where I live.
Okay, I'm gonna, thank you, Dr. Buckman. I'm gonna move along, and even though I'm not the official moderator of the session, I'm gonna try and get us on track a little bit with time. So we're gonna talk now about the Le Fort 3. I think Jack's gonna talk about Le Fort 3. I think he was actually supposed to go before me, but since this is us, we'll walk and roll. And I'm going to talk a little bit about the Le Fort 3 one, combination surgery or addressing the facial cascade. And I apologize that I don't have the ASMSM one on here. Usually I do. I will just say that I'm not going to go through this. I've presented this before, but this is what I was referring to. Each of us at this table, and many of us in the audience, have our own paradigm for how we take care of our patients based on the results that we typically get from each of these operations, which vary from surgeon to surgeon. And so what I've found as I've gone along, and many of you have inherited perhaps my patients as I have inherited yours, is it's really hard to pick up the paradigm from somebody else because you don't know what to expect. What I can tell you is that down in the mature patient, and this is the immature patient in terms of bone still growing, where distraction is a little bit more necessary and so forth, that the Lefort 3-1, possibly BSSO and genioplasty have become part of my armamentarium that I use more and more. And I'm not going to go through all that, but just to show. So the Lefort 1 and BSSO have been traditionally used to correct the lower face discrepancies. And I'm not talking about the lower third, but we really have used that for a little bit more than lower third in terms of the facial discrepancies and malocclusion. And the problem with this approach is that Lefort pattern is, of course, based on traumatic fractures, and this is a picture of René Lefort. These are not developmental patterns or growth planes, and so we're essentially treating congenital developmental anomalies with fracture pattern osteotomies. And the face is a complex cascade of bony prominences and depressions, both sharp and subtle transitions, not unlike it, complex waterfall like this. And yet we're treating, as an example, Lefort 1, you can see the osteotomies here, in an area that doesn't even represent anything embryologically in terms of a plane or a developmental division. And you can see that here in the patterns that we're all familiar with in terms of development. So the Lefort 3-1 combination is not new. It was performed by Obi Gieser in 1969, and then before that, Gillies and Tessier combined and described the Lefort 3 alone. Adding the bilateral sagittal split to that has been rarely described, but it's been performed, I think, by fewer surgeons, as we've talked about that. And the application of vertical surgical planning, which Steve can comment on at the end, maybe for like 60 seconds. I think it's helped this operation, not in terms of its predictability. I agree with Steve. The problem is we don't have metrics and norms to be able to say if you move the bone ahead 6 millimeters of tissue, soft tissue at the lateral orbit is going to move 0.8, and I think that's the point that he's making, just a little bit more in a verbose fashion. So the Lefort 3, though, one of the issues is, and I've overemphasized it here, but I moved the 3 and the 1 together in one piece, focusing on the orbits, and what happens is you can get an anterior open bite. On the other hand, if you focus in on the occlusion and you match up this Lefort 3 complex, well, then you can end up with an ophthalmos. And I think that this was an issue early on for me, is that I would focus a little bit more on trying to get both things done at once with the 3, which is trying to get the occlusion a little bit closer, but at the same time get the orbits and the malar prominences in a better position. I think most of us realize that that's not what the Lefort 3 is for, that it's an orbital-centric and malar-centric operation, and by combining these, though, it allows us now to focus in on the orbits and the malar prominences and get that upper third of the face in the proper position. But then here in the Lefort 1 segment, you can actually posteriorly impact, you can disimpact the anterior aspect of this, and then you can even set back the mandible. So now you are finishing off, and this patient would look probably better radiographically, but more importantly, would have better overall facial balance. If you look in the literature, there's not a whole lot there. There's 168 articles. There's probably a few more now since I've done this study in the Lefort 3. You combine it with the Lefort 1, you drop down to 67. You look at the stability, 16 of those articles on stability, but then you add a sagittal split, and there's nothing on the stability of doing these operations. And I'll admit right up front that we're in the process of collating all of our data, and that will probably be the first article that talks about a 3-1 BSSL and stability of movements. What we do know is that greater than 10 millimeters across the board in all of the literature has been deemed an unstable movement. So I'm going to use this guy as an example. He obviously has significant prognathism. He has mid-face hypoplasia, and he's got some facial asymmetry to boot. The left side is his maxilla is more cephalad than the right side in terms of his occlusal plane. You can see he's got very severe hypoplasia. He's got a fairly elongated nose, which we're going to make even longer by virtue of this operation. And this is him with an active smile where his lips even accentuate the discrepancy in his face. So this is a distorted face, otherwise normal kid. And if you look at his occlusion, he's offset with his mandibular midline off to the right of his maxillary midline, and he's got a negative overjet of, I think, 21 millimeters or so. Otherwise, his arches are pretty well coordinated orthodontically. He's got wisdom teeth 1 and 16 here, and he's got braces on, and the roots of his teeth look pretty good. He's got a deviation of his chin point to the right in comparison to his malar prominence. And then in the lateral set, obviously global midface hypoplasia. So we did the traditional tracing out of him. No big surprises there. Huge negative overjet, steep mandibular plane angle. And in my old toolbox, this is how we treated this. We do a Lefort 1, and then we do a BSSO setback. And since he's more prognathic, we take more of it in the mandible, but that really creates an unstable movement both in the maxilla and the mandible, with the counterclockwise rotation of the mandible, making it an even more unstable, and a possible three-piece. So if you look at the paradigm of William Bell, who's an oral surgeon who has described the stability of these movements in a hierarchical ladder, essentially you're making very unstable movements. Other than the Lefort 1 advancement, which is reasonably stable right here, once you start sectioning the midface, and once you start moving the mandible back, see midface wider or maxilla wider, mandible back, now you're creating incredibly unstable movements, and you're going past 10 millimeters, so that's about the worst situation you can ask for. So I'm going to show some old school acetate, which is the way we used to do it. And we traced this out, and then the plan, of course, was we were going to do a Lefort 1 advancement and a BSSO setback, and you can see the sizes of those movements I just talked about. Alternatively, now, the way that we look at accommodation surgery, and as I was explaining, I can get predictably 6 to 8 millimeters of movement at the midface. I find